generally, I really don't call it just stem cells. It's really biological treatments, because really what the treatments are really involve more than just stem cells, and it involves all the growth factors that are part of all these products that we use, whether it's the PRP or whether it's bone marrow concentrate, or if it's any of the umbilical or amniotic products. It's really about the growth factors as much as it is about stem cells. So we really call it biologic, and if you really want to get fancy in orthopedics, we like to call it orthobiologics, because we like to say ortho. So again, this is like 8-9 years ago, even Scientific American had a big story about the PRP thing, because all these professional athletes, started using it, and for various injuries. Tiger Woods had it and was able to get back and play. This Los Angeles Dodgers pitcher had a mid-season injury and was able to receive some biologic treatments and get back and play in the playoffs. The Steelers, a couple years back in the Super Bowl. So it really became a super hot topic. And my favorite athlete, Rafa Nadal, he suffered from chronic patella tendinopathy or jumper's knee for years, and he would always show up to the to the tournaments, and he'd have his knees taped. Sometimes he'd have one or both, and just suffered from it all the time and had to drop out of tournaments and just had chronic issues. And then back in 2013, he kind of dropped out and just said, I'm done for the year, and was gone for the last 7 months, but then came back the next year cured. No more tape. And he, it's rumored that he had patella, or he had PRP, or also people say bone marrow, and nobody really knows.
PRP, you keep saying PRP. What is it?
Oh, I'm sorry. PRP is platelet-rich plasma. So platelet-rich plasma is when we draw blood from the patient, and then we spin that blood and concentrate the cells in your blood called platelets. And the platelets are what we use, or the platelets are what your body's used to heal. I am going to touch on that, so apologize. I'm jumping ahead with the abbreviations. But anyway, so he came back after having these treatments and was cured. Didn't have any more problems. Of course, that was 5 years ago. Now he's starting to have problems again. So we'll see what happens with that.
He just won too, the games.
What's that?
He just won a game. I was watching him.
Today? So he's back.
No, but it was a couple of weeks ago.
Yeah.
They were playing. I was watching him. He's a good player.
He's awesome. Yeah.
He's really, yeah.
Kobe Bryant's another famous athlete that he went over to Germany and had basically a special kind of this biologic treatment called regenikine. That's whenever they actually take somebody's blood and they treat it in a heated way to change the proteins in a way that makes them more beneficial, and you create this one protein called IRAP, which is an interleukin receptor blocker. So that's basically a receptor antagonist protein, and interleukin is a molecule in our bodies that drives inflammation. So it causes a lot of pain, ends up causing a lot of pain. So this IRAP, which is highly concentrated in the regenikine, cuts down on the inflammatory changes, and he was able to get that. He came back and was able to continue to play. So that's kind of what gets this thing all started. The professional athletes got the public's interest peaked. They've been doing the stuff in Europe forever. That's why a lot of the folks end up going over to Europe.
Why is it not done here?
I'm sorry?
Why is it not done here?
Well, no, a lot of it is now. This is 8-10 years ago, where a lot of this stuff was not done here at all. There are some things that we can't do here still. It's all driven by the FDA. So there's some things we're allowed to do, and there's some things we're not allowed to do.
And insurance, right?
Yeah. So generally speaking, our goals are really to basically enhance healing by harnessing the patient's own natural ability to heal. So with all these treatments, that's what we're really trying to do. All of us, you injure something, and your body's constantly try to manage it and try to heal it. Unfortunately, the healing ability in a lot of these problems is just not there. So we're trying to make the patient's ability to fight off inflammation and heal an injury amplified. So we treat various things. I think the most common thing that we treat is arthritis. That most people have heard about that. But there's also other things we can treat. Tendon, muscle injuries, ligament injuries. It's been shown that these biologics can speed up and improve healing in many of these injuries. Degenerative ligament and tendon injuries like tennis elbow, and arthritis. So basically in arthritis, you're really trying to inhibit inflammation. We also know that it can stop further cartilage destruction, again by these proteins that block a lot of the enzymes that cause inflammation and also cause cartilage degradation. And then, the big million-dollar question is promote cartilage regrowth. There is some evidence that you can promote some cartilage growth in an arthritic joint using, in particularly stem cells or even PRP. We're just not to the point yet where we can turn the clock back. And I'll touch on that, but there is some evidence that you get some cartilage regrowth, but you can't turn a 50-year-old knee into a 20-year-old knee. Not yet.
That's what I came for.
So, yeah. So again, the big question is promote cartilage growth. So there's really, again, no evidence that you're going to reverse the damage. Once you've had bone spurs and once you've had joint collapse, we don't have the ability to turn that backwards. There's been several animal studies and even a few human studies that have shown some cartilage regeneration with these treatments, but it's at a small level that you're not going to really appreciate on an X-ray. And so that's one of the reasons I wanted to show this X-ray. So this is a standing X-ray of a patient. So it's always important to have X-rays standing up. Most patients that come into orthopedic clinic that have had X-rays elsewhere, whether it's at Penrad or Memorial Hospital or any of the other clinics in town, they usually do them with you lying down. And that's just because the radiologists, when they look at X-rays, they look at them different than we look at them as orthopedists. We're looking at very specific things. The radiologists look for specific things. But the only way to really know how advanced arthritis is to get an X-ray of you standing up. And we typically do two of them. We do one standing straight up, and we do one with you bending your knees slightly. And the reason we do the one with you bending your knees slightly is your X-ray can look really good when you're standing up straight. And then when you do one bent, it can collapse like this. And that's because that first part of the knee when you flex is the first part of the knee to become arthritic and to lose its cartilage. So that's why some people come in and they don't want to, they see us and they say, well, I've already had X-rays, I don't want to do X-rays. And we try to explain to them that this is why we want to do it. So most of the time if you come in with non-standing X-rays, we will repeat them. So promote cartilage growth. Be really skeptical if it sounds too good to be true. I get to look at this every Saturday and Sunday. This before and after X-ray that they have in the paper every week, showing this is the before and this is the after, and that's not happening. So if it sounds too good to be true, it's probably too good to be true. In terms of talking about cartilage growth, there's been a tremendous amount of research done in this area. A lot of it's been done over in Europe, and it has been shown in areas like this where you have. This is a knee. This is a condyle of a knee, or the distal femur, so the top of your knee right here where you weight bear. And this is a patient that had a traumatic cartilage defect. And you can see the cartilage down here, which is the leg or the tibia, and the cartilage around this all look still pretty good. And you can see how thick the cartilage is. It's pretty thick. That's like 5 millimeters thick, 1/4 inch. There has been some evidence that it can help this type of problem. So the rest of the cartilage is good, but you have a contained defect. That is something that a lot of times we can actually help, and we've seen cartilage regrowth, especially in laboratory studies. But in Europe, they're able to use some of this bone marrow and stem cell stuff and use it with collagen membranes and other things you can use to kind of keep the stuff in that hole and help it heal. So can it help you avoid surgery? Again, this is a promise made by a lot of the stem cell clinics, and again, it's trying to sell it, but it's really not an accurate claim. Now, there are times that it can be an alternative for patients if you're not a good surgical candidate or you just don't want to have surgery. So maybe it'll help you, buy you a little time, or maybe it'll just give you a little bit of pain relief. but it's not going to necessarily turn your symptoms around 100% and make you pain-free. So again, if it's too good to be true, then ask questions. There's many examples where somebody says, well, I understand that I have arthritis and I don't, I know that I may need a knee replacement, but, I'm only 55 and I want to put it off for 5 years. In that situation, it can be worth it if the arthritis is not too advanced. But there are a lot of patients that it's not going to help. And there's certain situations where it may help you, but you may need surgery first to address a specific issue. This is a case example of one of my patients. It was a 66-year-old female who comes in to see me about her knee, and her main complaint was a sharp stabbing pain that would catch on her and her knee would buckle and give way. She had this chronic achy, sore pain and stiff and swelling type stuff for a long time, but this was an acute onset issue. She had seen somebody about stem cells who told them that they could help her, but those symptoms are mechanical. So there's something in there that's not right. So I recommend we do an MRI before we do anything else. These are her x-rays. So this is her left knee, and it looks very normal. This is the right knee. It's a little bit diminished joint space on this side if you compare that side to that side, but not terrible. There's still some decent cartilage there. So we got an MRI, and this is what the MRI looked like. And you can see there's a fragment of meniscus right here. So she could do any kind of injection all day long, whether it's a cortisone shot or stem cells or anything. It's not going to make it better unless that's dealt with. So this is what she had. So this shows a little bit of the arthritic changes she has, a little of the rough cartilage and a little bit of loose cartilage, like a little flap. And then this is that piece of meniscus. So that's like having a rock in your shoe. You're not going to get rid of it unless you take your shoe off and dump it out. So we went in and we cleaned this up and cleaned up that, and she did great. So, and maybe after that the stem cells would help her if she wanted to do it, but it just wasn't something that was the right thing to do at the time. So this is what it looks like after cleaning up the meniscus. Still a fair amount of arthritis, which you can see here, but the main issue at the time was that mechanical meniscal defect or meniscal flap.
So you had to do surgery?
Yes, so we did arthroscopic surgery. So we went in with a camera and a couple little incisions and cleaned up the meniscus. Bottom line, there are times that surgery can improve your result with or without biological treatments. So if you have a meniscus tear, you have a mechanical defect like that. Another example is if you have a full cuff tear. I've heard some folks say they can heal a rotator cuff tear with stem cells, but if you have a complete tear of your rotator cuff and it's torn off the bone, any kind of injection is not going to make that tendon find its way back to the bone and heal. It has to be fixed for it to heal. So we're not to the point where we're really capable of reversing damage caused by arthritis, and really no one's better suited to help you determine this than an orthopedic surgeon. So there's several guys in the group that are doing this kind of stuff. The spine guys are doing this as well. I actually had the spine guys inject me. I had my back injected with bone marrow. So I'm a believer in it, and it helped me tremendously. So what are the options, or what are your options today? So autologous platelet-rich plasma, again, that's what we were talking about earlier, PRP. That's just a peripheral blood draw. So you just draw blood just like if you're going to a lab to get blood drawn. And then you take that blood and you centrifuge it in a device that spins the blood at a very specific rate for a very specific amount of time. And then it separates out the platelets. And the platelets are the things that really lead all the healing. Bone marrow concentrate, that's where we take bone marrow, usually from the pelvis or the hip. Amniotic fluid, that's the fluid that's collected at the time of a C-section birth. And the same thing with the umbilical cord blood products or umbilical cord products. So what is in bone marrow? Well, there's cells in bone marrow. The mesenchymal stem cells is really what we're looking for. But there's also hemopoietic stem cells that are responsible for making other blood cells. We do know that the concentration of the stem cells does decrease with age. There's been several studies to demonstrate this. So in older patients, if we took the same amount of bone marrow from a 20-year-old and a 70-year-old, the concentration of stem cells in that 70-year-old is going to be much, much lower. And then we definitely take that into consideration if we're recommending some kind of treatment. There are platelets in bone marrow, and then there's IRAP, that protein that I was talking about that Kobe Bryant got, that really shuts down the inflammatory process. So the role of platelets, its primary role is to help clot blood, but part of the reason they do that is they're the first cells to arrive at a zone of injury. So they arrive, they help clot, slow down the bleeding, stop the bleeding, but then they release their granules. And these granules are what release all what we call cytokines. Cytokines are the proteins that help block inflammation, but also stimulate new blood vessel growth and just stimulate new growth. So what's in those granules? Well, there's these energy molecules, ADP, ATP, serotonin, calcium, and then the alpha granules contain all these growth factors. And this is, 4 or 5 of them. There's really 30 different growth factors, in the granules of platelets that all just aid in that healing process. The IRAP, I kind of already covered what this is, but it blocks interleukin, but it also inhibits these we call matrix metalloproteinases. It's kind of a mouthful, but this is the enzymes that break down cartilage. So what about stem cells? Well, it's not just their ability to differentiate. They're really the ship's captain of the body. They kind of direct things. They're strongly anti-inflammatory, anti-apoptotic, which is basically cell death. Antimicrobial, so they help fight infection. And they induce cell proliferation, angiogenesis, and reduce scars. So they're basically promoting growth of tissue, bringing in new blood vessel growth to bring more nutrients to help the healing process.
Where do you get the stem cells?
The stem cells can come from various places. The bone marrow is one. That's one of the primary ones that we do. And actually, let me go back here for a second. So, in your bone marrow, you have blood, all the blood-forming products, but then the stem cells actually live on the trabecula of the bone. So inside your bone looks, the outer shell and then inside is very porous. And it's made up of like a trabecula. So it kind of looks like a pumice stone, if you know what a pumice stone looks like. So but on those little fibers and that lattice work, the stem cells kind of live on it like this. So these are stem cells. So when you go in to take the bone marrow, you're getting the marrow, but then you're also getting the cells off of the trabecula. The other alternative is using the afterbirth products like umbilical cord products and umbilical cord blood, those type of things. I do have a video of how we get bone marrow. Does anybody want to see that, or is anybody just totally against seeing that? It's pretty quick. So it's like a little 3-minute video, but I thought that would be. Okay. So it's kind of. So basically, this is a patient we're doing this in surgery actually. So they're basically laying on their side. And see, I'm palpating the midline. This is on their back. The PSIS is the posterior superior iliac spine, which is a little bump you can feel on either side of your lower back. And that's where we get it usually. So it's pretty simple. You put a little local anesthesia in, which basically just numbs it up, and you numb up the skin and the periosteum, which is the lining around the bone, and that's where all the nerves are. The bone really doesn't have any nerves. So once that's numb, you don't really feel anything. You may feel a little pressure, but there's really no pain. So once it's numbed up, you make literally a 2-millimeter incision. It's tiny because it only has to be big enough for the large needle or the trocar to go in. And we do this in the office, so it's not that bad. So.
You give patient sedation?
No, not in the office. We don't. So this is the trocar. So you can see it's just basically a large bore catheter, and it's got a pointy tip, and you just literally tap it in. It looks worse than it is. But then once it's in, you just kind of gently push it in. And again, once the periosteum is anesthetized, you really don't feel pain. It's a little bit of pressure, but that's about it. And once you're in, you can just literally suck the bone marrow right out, just like you were doing on an IV. So we mix the bone marrow with something called ACDA to keep it from clotting as you're drawing it. So after I get the first little bit, I mix it up so that it makes it nice so it doesn't clot. And then because the stem cells are actually on those little trabecula, if you just sat and just kept sucking out of the same spot, you would run out of stem cells really quick. So you kind of have to rotate, because the holes are only on one side of the trocar. So you rotate it, and then rotate it, and then once you kind of go through a full rotation, you kind of redirect to a different place. Because once you exhaust the stem cells in one particular area, you need to move to a different area to make sure you're getting stem cells. So typically, we draw 90 mils if we're doing one injection.
On the stem cells you're taking out, how long does it take to regenerate stem cells in that area that you've taken out?
You mean in your own pelvis?
Exactly.
That's a good question. I don't know if I can tell you the specific answer to that, but your body's constantly kind of remaking this stuff just on a continual basis.
You don't have a void or anything?
No. You know, you're doing that anyway. You're remaking these things constantly anyway, just like you're reproducing your blood cells and your platelets and everything else is constantly being remade.
And then do you do both sides?
Only if you're doing more than one joint, you go to both sides. But then you basically pass. This is the device. This is the centrifuge. This is basically called the Angel. It's made by a company called Arthritic, and basically you put it in, and then once you get everything in, you spin it. And that separates out all the cells by weight. And then, once the cells are separated, this person we're actually injecting into a knee. We're doing it after we did an arthroscopy. And once you get it into the joint, the stem cells kind of direct it from there, and they go where they need to go. So, but that's how we get bone marrow.
So Dr. Jones, no longer from the sternum, just out of the iliac crest.
The sternum? Oof. Well, I wouldn't want to take it from the sternum. Maybe the cardiothoracic surgeons would be comfortable doing that. Yeah. I know. I remember they used to do that. I definitely wouldn't do that in clinic. Yeah.
Is the PRP mixed with
Yeah,
the
there.
marrow?
When you take the bone marrow and when you spin the bone marrow, essentially what you end up with is PRP. But because you took it from the pelvis, and the source of it is bone marrow, that's why you have stem cells within that sample. Whereas when you take it from peripheral blood, there's no stem cells in your peripheral blood, so you don't have stem cells in the peripheral blood PRP. Does that make sense? I'm sorry?
The PRP is already included in the stem cell mix then, or there is no PRP?
No. What you end up with after a bone marrow aspirate and then you spin it to concentrate it is PRP. But it's PRP from bone marrow that has stem cells in it. So bone marrow concentrate has platelets that are concentrated after the centrifuge, and it also has what we call MSCs or mesenchymal stem cells.
So would the 70-year-old be excluded from that and just go in with the birth product?
That's a discussion I have with everybody of the options. I am going to talk about something else coming up here. Let me finish that, and then we can readdress it. But I discussed the options with everybody if people are interested. I have done bone marrow on 70-year-olds. But I'll talk about the next thing first, and then we can come back to that. So there's a lot of literature support for bone marrow. There's several articles. This is basically a pain scale. So 9 being obviously more pain, 0 being no pain. And this is after a bone marrow injection. This goes out to 12 months. So in the different levels here, this is somebody that has grade 4 arthritis, which is basically bone on bone. And this is somebody that has grade 1, which is basically just a fairly normal looking x-ray but has cartilage degeneration. So obviously the severity of arthritis can really affect how much it helps. But even patients with grade 4, a lot of them still can benefit, but it's going to be less. And you can see here at the end it even starts trailing up a little bit. So I mean, if you follow that on out, it probably wouldn't work as long either. This is another study that just looks at improvement in quality of life scores. And again, just universally, they improve. Trying to remember how long this was out. I can't. Yeah, so this one's only out to 6 months. There are studies that even out to 5 years that still show some benefit with the bone marrow. There's other applications. This is a patient that had, or this is an article about patients with non-unions where it's basically a bad fracture that didn't heal. And it turns into this established non-union or non-healing fracture. And this is something a lot of the trauma guys do, where they'll inject bone marrow into the non-union, and then it goes on to heal. There's also a lot of evidence, or mounting evidence, I should say, to show that it does help when it's applied along with surgery, for rotator cuff repairs as an example. This is one study. There's a lot of studies out. There's not a lot of definitive data for rotator cuff tears yet. It's not something I incorporate regularly into my practice. I have done it some if patients are really interested, but I can't tell you based on the literature that it makes a difference in everyone. I believe that one day that we'll have the literature to support it, but we just don't yet. In meniscus surgery, this is predominantly in a younger person's problem if they have a meniscus that's repairable. You can actually get the meniscus to heal, or even treating it in patients that have partial meniscectomy, like that patient I showed you earlier, where you can do the meniscectomy that's causing the acute problem, and then add this on as an additional treatment to help the arthritic symptoms. And that's something I've been doing more and more of. If I'm scoping somebody with a meniscus tear, offering them that, because I've seen definitely improved results. Again, there's not a tremendous amount of literature. There is some, but I personally have seen a big difference in how those patients do after a meniscectomy.
Chris, when you say that there's not enough study here, what about studies in Europe? I mean, have they been studying it, and do they have any more follow-up on that?
Not really. Not really. I mean, basically all the literature that I'm quoting, a lot of it is worldwide. Okay. It's not all U.S. literature. I mean, all of, I don't think these guys are all from the U.S., but, a tremendous amount of this literature has been done overseas because they don't have the restrictions that we have. So getting what we call an institutional review board to approve a study here on something that's so experimental is difficult. So we're talking about ligament injuries. I've also seen myself, and I do this quite a bit for MCL injuries, which is a medial collateral ligament of the knee. That's the ligament on the inside of your knee right here. That it's common in athletes that take a long time to heal. These things, people come in even 6 months out and are still having trouble getting motion back and still having stiffness. And there's been several studies that show that it really can improve the speed of healing and the rapidity of healing. There's also a study out of the NFL. I don't think I didn't put it in here, but there's a study where they looked at NFL athletes where they treated an MCL injury with PRP. And the previous amount of time return to play was 90 days, 3 months, and they were able to cut that in half and get it down to 6 weeks. So with an MCL injury. So other options. So amniotic fluid. This was kind of a big deal for a while, and there are still a lot of places that still use a lot of amniotic fluid. It was, of the non-autologous options for stem cells, this was the most affordable for quite a long time. It's basically the fluid that's collected at a C-section that mothers donate. It has an abundance of anti-inflammatory proteins and growth factors. Some of this fluid does contain stem cells, but as we've kind of gone on, we've learned that the stem cells that are in this are probably not viable most of the time. Early on, alive, they're not living. I think the processing for this has changed because the demand has gone up so much. So they're just cranking it out as fast as they can. So a lot of that's processing quality. But even without live stem cells in the amniotic fluid, a lot of people do get benefit in terms of because all the anti-inflammatory proteins can really help. Help the inflammation that's causing a lot of the pain. This is one of the amniotic products that I've used. Again, just an abundance of growth factors. The umbilical cord matrix, or what's referred to as the Wharton's jelly, that's basically the substance of the umbilical cord. So it's what surrounds the vessels in the umbilical cord to protect it. That's where you really have a really high concentration of live stem cells if it's prepared properly, but also the growth factors. So this has become an increasingly popular product to use. And even a few years ago, it was too expensive to even think about offering anybody, but here recently it has become more affordable, and it is an option. So there's studies that have looked at the viability of mesenchymal stem cells within the Wharton's jelly. So this is the umbilical cord, so you got your vein, you have your artery, and then the Wharton's jelly is all this other stuff. But what they've found was that the MSCs are the stem cells that they get out of Wharton's jelly are very durable. They tend to last a long time. They have the ability to differentiate into multiple different cell types, whether it's fibroblasts, which make collagen, which can heal tendon or heal ligament. They can also differentiate into chondrocytes, which make cartilage. And some studies have shown increased capacity for proliferation, meaning how many you put in this many, how many it ends up multiplying into, more so than bone marrow. Again, these are small studies, though, and small amount of studies. It's hard to really say anything with that's definitive with this stuff yet because it is so new. So this just shows a study that did show the chondrogenic differentiation of these umbilical cord cells, meaning that they showed in the lab that they could actually differentiate or stimulate these stem cells to become cells that make cartilage. This is a dog study. So again, a lot of this stuff is still animal studies. And this did show that these animals did show improvement in the cartilage on MRI with treatment, but no change in the X-ray. So take-home points, we don't have the fountain of youth. We are getting closer. I don't think we're real close, but I think we are learning a lot, and we have to at least have some tools that we can use to help people. If you're going to consider it, you really should have somebody look at you and have a thorough evaluation by somebody that really understands these problems and has a really in-depth understanding of what the treatment options are.
And who would that be?
That would be the orthopedic surgeons. And ask a lot of questions. What are your goals of treatment? That's something that your doc should be asking me. That's what I ask everybody. Well, what do you want out of this? I mean, what do you really want? What are you trying to gain? Are you trying to be cured? Are you trying to just feel better? Are you trying to feel better, buy yourself a couple of years? And then also understand what is being used. We want to ask for detailed information about what they're actually going to put in your body. And what's their training? So if you, what kind of training do these providers have that are offering these treatments? So I think there is significant potential to help if you're a correctly identified patient. So, and again, as long as you understand what your goals are, and if we can help you understand if we can actually help you attain those. Patients that have arthritis that aren't surgical candidates, whether they're have too many medical problems or just too high of a risk. Is it a very young patient? I mean, we see patients that are in their 40s that have just completely arthritic knee, grade 4. You do a total knee in that patient, they're going to end up with another one and maybe another one. You know, the younger they are, the harder they're going to be on it, and you know, even a perfectly done knee is, you know, may only last 20 years. You know, if it's done perfectly. Degenerative tendon issues like tennis elbow, I do think partial cuff tears, you know, can benefit from it. Jumper's knee, plantar fasciitis. My partner, Dr. Drescher, has treated a lot of foot and ankle stuff with this. Disc disease. So that's the spine guys are starting to do more and more. They were looking at it for quite a while and trying to get in it and getting out of it, and I finally prodded my partner enough to get him to inject my back about a year ago, and it's made a world of difference for me with my back, and so I think for the, again, properly selected patients, I think it can help. And acute ligament injuries like the MCL tears that we talked about. That's all I have. I wanted to leave enough time for questions, but I'll touch on your question now. So basically, when somebody comes in and they're interested in a treatment, I discuss options. You know, and the age is definitely something to consider. You know, I have done bone marrow on folks in their 60s and their 70s, but it's a discussion we have together if you want to try that. And the argument I make for it is that despite the fact that there are less cells within the bone marrow, there's more literature to support it than there is the umbilical products. If you just look scientifically at what's in the stuff, I mean, there's definitely a lot more stuff in the umbilical products, but we just don't have a lot to back it up yet. So it's kind of a discussion you have. I think they're both great, and I've seen good results with both. So again, it's kind of a decision you make together. Plus, you know, with the umbilical stuff, you don't have to do a procedure. You know, you're not having to take bone marrow. And some people just say, I don't like needles, I don't want any part of that. You know, so they really don't even think about that. But it's a decision we make with the patient.